Hello, Assalamu alaikum everyone. My name is Dr. Farooq Javed and I will discuss about the neural tube defects and their management. So this is the outline. I will start with a short note on the embryology, then I will show you different types of neural tube defects, their possible risk factors, clinical features and investigation we usually go for, and then the associated anomalies that can be seen along with these neural tube defects, and in the end I will discuss about the management. So starting from the embryology, every one of you know that the neural tissue is formed from the ectoderm, and the ectoderm that forms the neural tissue is called the neuroectoderm. And the neuroectoderm starts at the neural plate that starts to roll on its edges and form a tube-like structure that is called the neural tube. And then there are few cells that are separated from the ectoderm and also the neural tube and form the neural crest cells, and the center of the mesoderm is called the notochord. So neural crest cells will form the peripheral nervous system, neural tube will form the central nervous system like brain and the spinal cord and their structures, and the mesoderm surrounding the notochord will form the vertebral body and all the bony structures of the skull and the vertebra. So at the fourth week of gestation, we will have two openings uh, after after closing or the formation of the neural tube. One opening will be the cranial neuropole that will close at the 24th day of gestation, and there will be a caudal neuropole that will be closed at the 28th week of gestation. So here you can see the formation of different brain structures over the weeks, and in the fourth week of gestation, when the neural tube is formed and also closed, there will be three primary brain structures. They are called the prosencephalon, forebrain, mesencephalon, midbrain, and rhombencephalon, the hindbrain. Then over the next week, they will further divide and form five structures: telencephalon, diencephalon, mesencephalon, metencephalon, and myelencephalon. And then over the coming weeks of gestation, they will uh, form different brain structures, and their compositions will be like the telencephalon will form the cerebrum, or the main part of the cerebral cortex, and also the lateral ventricles. Diencephalon will form the central structures like thalamus, hypothalamus, and also the retina, and the third ventricle as well. Mesencephalon will form the brain stem and the cerebral aqueduct. Metencephalon will form the brainstem, but the pons and the cerebellum as well, and the myelencephalon will form the medulla oblongata. A spinal cord will be formed at the lower end of the neural tube. So here you can see we generally divide the neural tube defects into two types: open and closed. Open neural tube defects can be anencephaly, encephalocele, spina bifida, hydranencephaly, iniencephaly. Then the closed one are the lipomyelomeningocele, lipomeningocele, and T-third cord. So the anencephaly, there will be absence of the cranial vault, and the most of the cerebral hemisphere either will be reduced in size or completely absent in these children. Then the cranioschisis, there will be a defect in the skull through which the neural tissue will protrude out, and these children are incompatible with life generally. Then exencephaly, there will be protrusion of the brain and meninges out of the skull, and they will present outside the uh, skull. Then the rachitis, the meninges and the spinal cord will be exposed through the fissure or the opening within the vertebral column, and there will be limb weaknesses and the neural defects. Then iniencephaly, there will be a retroflexion of the head without a neck and a severe distortion of the spine. There will be retroflexion of the head in these cases. Then the hydranencephaly. The cerebral hemispheres are generally absent or reduced to very minimum size, and they will be replaced by the sacs filled with the cerebral spinal fluid, and there will be largely growth retardation, and generally they do not survive for long. Then encephalocele, there will be protrusion of the brain and meninges into a fluid-filled sac through a skull defect. There are generally different types of encephalocele, and the common one are the occipital encephalocele, and then there can be the frontal encephalocele, or which are called the frontonasal encephalocele. Here you can see the CT scan of the encephalocele, the neural tissue, and the meninges are all protruding out from the skull, and this is the MRI. Here you can see the meninges, and the fluid filled cavity is also outside the skull. So this is occipital encephalocele. These are to be differentiated from the spina bifida of the cervical spine. So here we are at the spina bifida, the most common spine, the neural tube defects, and which we will discuss in detail. So spina bifida is incomplete closing of the spine and membranes around the spinal cord. So the spinal cord will not be formed as normal, and there will be defect within the spinal column, and the spinal structure or the neural structure will protrude out. There are different types of spina bifida we will discuss in coming slides. So these are different types of neural tube defects: anencephaly, cranioschisis, spina bifida, and anencephaly, encephalocele, and spina bifida closed one. So what are different risk factors? So generally, there are few risk factors we'll look for when a child presents with the neural tube defects. Generally, we ask about the folic acid deficiency within during the pregnancy, and ingestion of the folate antimetabolites, and then the gestational diabetes is one of the risk factor for the neural tube defects. Then the obesity during pregnancy, arsenic poisoning, radiation, and cigarette smoking are the less known risk factor for these neural tube defects. So now coming to the spina bifida, we will discuss in detail. There are different types of spina bifida. Generally, there are three different types of spina bifida. Here you can see this is the normal spine. The neural structure are within the spinal column, and there is no defect or breakage in the vertebral column. In the spina bifida occulta, there will be defect within the spinal column, but there will be no protrusion of the meninges or the neural structure out of the spinal column or the spinal canal. In the meningocele, there, along with the defect of the bony structures, there will be protrusion of the meninges, and the CSF cavity will be formed outside the spinal column. So this is the meningocele, where the meninges will also be protruding out along with the defect. In the meningomyelocele or the myelomeningocele, we call, there will be protrusion of the meninges as well as the neural tissue, which is the spinal cord, out of the spinal column, and there will be CSF filled cavity outside the spinal column. So these are the three different types of the neural tube defects: spina bifida occulta, meningocele, and myelomeningocele. So here you can see this is the fluid filled cavity outside the spinal column, and but the neural tissue is within the spinal cord. So this is the meningocele. Another a picture showing the protrusion of the meninges, but the spinal cord and nerves are within the spinal canal, and so this is the meningocele. Here you can see the meningomyelocele, where there will be the protrusion of the neural structure of the neural tissue along with the meninges, and this will be the meningomyelocele. So spina bifida occulta, there will be a bony defect, and generally they have a tuft of hair at the this bony defect, and there will be no bulging out of any structure, and so they generally present for the cosmetic reasons, or there can be the presentation can be the neural defects like low limb weakness can be seen in these cases. But the meningeocele will have a fluid-filled cavity outside the spinal column, and there are chances of this cavity to burst out, and it can cause the meningitis. Then the meningomyelocele, there will be the tissue, uh, the neural tissue along with the fluid-filled cavity, that is the meninges out of the spinal column. So what can be the clinical feature? Generally, when we talk about the spinal diseases, or specifically the neural tube defects, we usually look for three things. One are the local spinal changes or the local findings, that in these cases will be the sac-like structure at the back of the child, or the tuft of hair, or there can be burst uh, meningocele or meningomyelocele. So this will be one local presentation of the spina bifida. Then we look for the neural defect or the neurological deficit we call, and we will be looking for the lower limb weakness, and in the end we will see the sphincter weakness. Is there any weakness in the sphincters, or the urinary or fecal incontinence can be the presentation. So generally we look for three things. One is the local signs or the local findings or the local presentation. Then we will see the neurological deficit in the lower limbs, and in the end we will see the sphincters function. But there can be associated anomalies in these cases, and there will be further clinical feature or symptoms along with these general presentation. And so there will be um, learning disabilities, visual impairment, stunted growth, mental retardation, difficulty in movements, and facial defects, increased muscle tone, respiratory issues, and then can be the associated hydrocephalus that can cause vomiting and head enlargement, and cardiac anomalies can also be presenting with these neural tube defects. So what is the workup we generally do? Generally, we go for the MRI whole spine to see the neural tube defects. Here you can see the MRI of the whole spine. So there are the two views. One is the sagittal and the coronal views. Here you can see that there is defect in the neural bony structures or the spinal column, and there is protrusion of the neural tissue as well as the meninges out of the uh, bony structures, and they are forming the sac-like structure outside the column, spinal column. And as you can see, there are defected uh, bony elements in this MRI as well. So this is generally the most common investigation we go for. This is the MRI whole spine. At times we also go for the CT scan of the spine to see associated bony anomalies, and this can help us in surgeries as well. Then there are other investigation that can be done prenatally to detect the spinal column defect or the neural tube defects. These can be the serum alpha fetoprotein, and the prenatal ultrasound can also detect 90 to 95% of the spinal bifida in expert hands. So this ultrasound along with the elevated alpha fetoprotein can be very helpful in the pregnant ladies to detect these neural tube defects. Then also we can go for the amniocentesis, and amniotic fluid alpha fetoprotein levels can be helpful. So what are different types of associated anomalies that can be seen along with these neural tube defects? So generally the most common uh, anomaly or associated thing that is seen with the spina bifida occulta is the hydrocephalus. So most commonly we go for the CT scan brain or MRI brain as well when we are uh, going for the MRI whole spine to see if there is any hydrocephalus along with this spina bifida or not. But then we can also see uh, the Dandy Walker syndrome, where The posterior fossa is generally com- filled with a large sac-like structure that is the CSF filled cavity. So this is the Dandy-Walker syndrome that can be associated with the neural tube defects. This is another view where you can see the posterior fossa is completely filled with the fluid and the sac-like structure. So this is the Dandy-Walker syndrome, and Dandy-Walker syndrome also generally present with the hydrocephalus as well. So another anomaly that can be present along with these neural tube defects is the carry malformation, where there will be the downward migration or herniation of the posterior fossa structures into the spinal canal through the foramen magnum. So this is the carry malformation through the foramen magnum, and generally the carry malformation type 2 is associated with with the meningomyelocele or the spina bifida. Then there can be associated other anomalies like the club foot or the orthopedic problems or the other bony uh, defects, and the urogenital defects like the urinary incontinence can be seen along with these neural tube defects. So the treatment. So generally the treatment is divided into two types: perinatal management. So we can go for in vitro repair of the spina bifida. So this can be done in two ways. Then we have the conventional or the open repair after the birth of the child. So prenatally we can go for the open repair or endoscopic repair. In the open repair we go for a C-section. Uh, C-section for the normal or the full-term baby, and we can do the open repair and then put back the baby into the uterus and then wait for the full term and the normal birth. This is the open type of repair, and then we can have endoscopic repair as well, where we can put two or three endoscopes and repair these neural tube defects. Generally not done in the Pakistan, but there are researches on these things, and in future there can be this can be a normal management of the neural tube defects. But generally we go for the open neural tube repair. So this can be the we call it the postnatal repair or the afterbirth repair. Here we generally the ideal thing is to repair these neural tube defects as soon as possible. But generally we give the indication of this repair within the 36 hours of the birth, because then after this time there will be growth of the uh, infection, and there can be associated meningitis, and even if we repair there are high chances of infections in these cases. So as early as much possible the repair should be done. The repair is generally cosmetic, because the neural or the neurological defect that is present at the birth will remain forever. Generally, generally the neurological deficit will remain forever, but for the cosmetic reason and to save the child from the meningitis and infection and burst out of these fluid filled cavities, we generally go for the early repair of this neural tube defect. So we generally open the skin in an elliptical incision, and then we take out the fluid and we try to save the the neural tissue and then put it back into the neural canal and close in multiple layers, so that there will be no bulge out or the no uh, sac like structure after the repair, and there will be no CSF leak, because the CSF leak can delay the wound healing or let it burst out again, and there will be the meningitis if there is CSF leak. So here you can see different uh, levels of surgeries. So first of all we give the elliptical incision, then we open up the skin and we take out we try to save the dura as much as possible, because this is the ideal cover for the neural tissue. So we open the dura and all these arteries are placed at the dura, and in the center you can see the nervous tissue in the third picture. And then then we try to put back this nervous tissue within the spinal canal, and then we repair the dura in a continuous fashion, so there is lesser chances of CSF leak. And over the dura we again try to uh, put the skin and the soft tissue in multiple layers. So these can be the post-op complication. Top of the list are the wound infection and the meningitis. Then the sepsis, sepsis coming from this meningitis can be a post-op complication, and the hydrocephalus is one of the commonest complication after the wound infection and meningitis. Then we can also have the carry malformation associated post-operatively with these neural tube defect surgeries, and the teethid cord, scoliosis, dermoid cyst, latex allergy can be seen in these children because they are early exposed to the latex gloves, and there will be allergy in the future life. And then there can be the death associated with these, and post-op complication can be seen in these neural tube defects. So this is all about the spinal bifida defects. Thank you so much.